Thank you so much, Nini, and thank you, everyone. I know I'm mindful of the time. We have 10 minutes to present, but today I'm here with Aiden Reynolds and Shannon Hardin, members of my team, and Shannon led the quantitative analysis of this project. And so I'm going to give kind of like high-level overview of the findings from our evaluation of the referral initiative for wraparound support. And first of all, a big shout out to all the partners, the community health centers, that were part of this initiative. It actually showed the amazing work that we can do with the partnerships and the collaborations. And so I'm going to give a little bit of background to set the context straight. So as a result of diagnosis or probably people being exposed to COVID-19, it was difficult for some people, for members of our various population groups, to actually follow public health guidelines. And this difficulty was as a result of a range of barriers like language barrier, income, food insecurity, just to name a few. And so in response to that, Ottawa Public Health and the OHTSO partners implemented this initiative to offer support to people who are isolating, so as to enable them to safely isolate while accessing the necessary supports that they needed. And so this diagram is a schematic illustration of the referral process. So what happened was that when an OPH case manager identified a client who would benefit from additional support, there were criteria that the client had to meet. They offered the client support, and if the client consented, then the client's information, including the additional supports that they needed, would be imputed into an online referral form, which was assessed by the triaging team at Southeast Ottawa Community Health Center, who then took this information and triaged the clients for further support from other community health centers and community organizations. And so the objectives of this evaluation, we tried to, and we had a couple of questions we wanted to answer from this evaluation, and it included, wanted to know how many people that were reached through these referrals, their characteristics, including their socio-demographic characteristics, and also wanted to understand their perceptions, the perceptions and experiences of both the clients and the service providers. And we're going to use this information to, describe lessons that we learned and made recommendations from these lessons. And so the method that we used, we tried to scope the initiative by creating this logic model to clearly describe the different domains of the initiative and the various indicators for which we collected data and measured the process and the outcome of the initiative. So for the outcome, we wanted to know if the initiative achieved these desired outcomes of supporting the clients and enabling them to fully isolate, without going out of their houses. And with regards to the process, we wanted to understand what worked and what didn't work. And for the qualitative piece, we interviewed service providers and the clients to understand their perceptions around the initiative. And for the quantitative piece, we combined data from the online referral form with data from the COVID-19 database that we had to describe the client's social demographic data characteristics. And so these are the findings that we got. So a total of 895 referrals were made from inception up until June 14, which was the mark that we gave for the evaluation. And 988 unique individuals were reached. And this graph shows the number of individuals referred by a weekly basis. However, we acknowledge that this initiative likely reach more people if we considered additional family members of these unique individuals. And with regards to the number of additional supports that we got, so for the additional supports that were offered, a total of 467 referrals were made for additional support. And on the right, we see that the highest proportion was for food support, followed by other supplies like primary healthcare services and activities and toys for the kids. And we had 686 individuals who gave us provided complete data for age and sex variables. And here we see that a little more than half of the participants were females, and close to half were between 30 and 59 years old. And for the race and knowledge of official language variables, we had 339 individuals who provided complete data for this. And using these data, we were able to identify that more than half of the individuals identified as racialized people, with the highest proportion being from Middle Eastern and Black race. And 9% of the participants had neither knowledge of English or French. And also for the household size, sorry, just a moment. Also for the household size and household income variables, again, we had about 339 individuals who gave us relatively complete data for these variables. And the highest proportion, we noted that for the household size, close to half of them, had belonged to households with 5 or more people, and people who earned less than $30,000 per annum had the highest proportion for the household income. But again, we had some caveats to this data, because a large proportion of these data were preferred not to answer, do not know, or missing data for the household income. And clients were referred from various neighborhoods across Ottawa, but the highest numbers were from the Ledbury, Heron Gates, Richmond neighborhoods, and Overbrook, MacArthur. And looking at the total supports that were offered, we offered various supports like food, mental health supports, testing supports as well. And with regards to, so I'm just looking at my, sorry. With regards to the outcome indicators, we noted that overall, the clients were satisfied with the supports that they got, and the supports helped them to isolate as required by public health. And if they had the opportunity to use these supports again, they would do that. And for the providers, this initiative gave them an improved sense of purpose, that they were doing meaningful work, and they preferred the new ways of working, the effective and convenient ways of communicating with clients and their colleagues, compared to the old pre-pandemic periods when clients had to come into the offices to sign.
I'm sorry, you're
almost done.
Up.
Oh,
so,
sorry.
Okay. You want to just wrap up?
Yeah.
Thank you.
All right. So just a summary. So in summary, we noted that overall the evaluation showed that providers were able to match clients' needs with supports aided. However, we have to continue the ongoing work so that we can continue to address the long-term health equity issues in our communities. And based on that, we made a few recommendations around planning and resourcing and systemic supports. And then when we reflect on this initiative, what it showed is that the initiative underscores the importance of collecting social demographic data, because we couldn't have described these clients and the supports that they needed if we didn't have SDDs. And building on this work, OPH is prioritizing the consistent collection and use of SDDs. And these are a few of the action items that we have started implementing with regards to collecting SDDs. And I'll just mention 2 of them. We've included the health equity goal into our OPH strategy refresh, which shows the senior leadership's commitment to this health equity work and the social demographic data collection. And also we are continuing to engage interested Ontario public health units to explore the idea of standardizing SDDs across various data systems. So with that, I think I'll stop the presentation now, and I'm happy to respond to any questions subsequently. Thank you so much.